Good morning, everyone. My name is Jeannie Long, and I'm from Save the Children. I'm a school health and nutrition specialist. Can everyone hear me? Perfect. Okay. So I will get us started. Welcome, everyone, to the September 2018 Fresh School Health and Nutrition webinar. This is Jeannie Long from Save the Children. The Fresh webinars are a series of monthly presentations on school health and development in low and middle income contexts, jointly organized by Fresh partners. This month, we are commemorating World Sight Day, and the theme for this year is Eye Care Everywhere. This is especially important given that 3 out of 4 vision impairments are avoidable, and especially among those most vulnerable, including young school children who are unable to see the board. Today we have 2 speakers with us from Sightsavers. Dr. Imran A. Khan is the Chief Global Technical Lead for the organization's work in eye health, inclusive education, and social inclusion. Sightsavers is a leading nonprofit operating in over 30 low-income countries. He is the director of the School Health Integrated Programming Initiative, developed by Sightsavers and PCD with support from the World Bank and GPE. We also have with us Guillaume Trotignon, a research associate at Sightsavers, where he focuses on health economics. At Sightsavers, he was in charge of the Global Trachoma Mapping Project costing study and of an urban eye health study in Pakistan. So today we will have about 40 minutes of presentation, and then we'll leave 15 to 20 minutes of Q&A. So if you have any questions, please write them in the chat box, and we will either answer them on the spot or we'll save them for the end of the webinar. And Imran, go ahead and get us started.
Sure. Thank you, Jenny. Next slide, please. So I want to thank all of you for joining us for something that I feel very passionate about. Given my own personal experience, having started wearing glasses when I was a 9-year-old child having a difficulty seeing the board at school. And this first pair of glasses not only helped my visual functioning, but also helped me participate more equally in my education and really reach my potential. And I'm sure all of you on the line who have worn glasses or contact lenses can relate to this impact that your eye health or your need for glasses has had on your education. So really, very simply, health affects a child's ability to start school, stay in school, and learn in school, thus affecting their potential to go on and live productive lives. This can be further illustrated when we think about the effect of eye health on education, considering that 80% of learning is visual, yet 10% of students in developing countries have poor vision. Slide 3. The leading cause of poor vision is uncorrected refractive error, accounting for 42% of visual impairment globally. I was fortunate to have this issue detected early and corrected with a pair of glasses. Yet for millions of people globally, this condition goes either unnoticed or untreated due to a market failure when we look at both supply and demand side dynamics. On the supply side, there's not enough trained human resources to test and prescribe a pair of glasses, as well as the lack of diagnostic equipment and of quality and affordable spectacles. On the demand side, often parents, teachers, children are unaware of the benefits of spectacle wear, and indeed there's often a stigma associated with wearing glasses. The response has been school vision screening programs, and these vision screening programs are not new. However, these programs have often been uncoordinated. They've lacked standardization and been on an ad hoc basis. For example, when there may be some funding available, then a group would go in, screen children, and may or may not give glasses. However, the issue is that a lot of these school vision programs lack the sustainability and are not built into systems. Slide 4. So the response has been that Sightsavers, along with Partnership for Child Development, PCD, with supervision and funding from GPE through the World Bank, has developed a school health integrated program initiative that set out to demonstrate that schools can be used as an effective platform to deliver health interventions using 2 health interventions as models, and those are deworming and vision screening as entry points. As well as we set out to raise capacity and engagement among governments towards comprehensive school health and nutrition. And most off, we really wanted to create a foundation by which countries have awareness, capacity, as well as operational and technical resources to include school health and nutrition into their education sector plans. Slide 5. Within our model, we brought together ministries of health and ministries of education to raise awareness, build capacity, as well as engage in joint planning for this initiative. Training was carried out, bringing together master trainers to train them on both deworming and vision screening, which was then cascaded down to teachers who would then conduct the vision screening and the deworming activities at the schools. And then for the children who have failed the vision screenings and were identified through the teacher screening programs, those children would then be further assessed, treated, or referred by a mobile refraction team that was associated with Ministry of Health that would come to the school and provide these services. Next slide. So in summary, the SHIP approach integrated deworming and vision screening and used schools as a platform to deliver these health services. We adopted standard guidelines and protocols, and on the right-hand side of the slide, you will see 4 technical manuals that were produced for the project. And within these standard guidelines and protocols, we adopted the use of a simplified vision screener that would make it easy for teachers to screen the children, as well as ready-to-clip spectacles, which you will see on the bottom left-hand side of the slide, which were supplied by Essilor. And this ready-to-clip system allowed children to choose from a variety of different colors, styles, etc. of frames, and then we were able to clip in lenses of different powers into those glasses and then dispense those glasses on the spot to the children, which made for a more cost-effective approach that Guillaume will describe in just a moment. Next slide, please. So really, when we look at the overall results and conclusions of the initiative, that we piloted the initiative in 4 countries, Cambodia, Ethiopia, Ghana, and Senegal, and we reached over 57,000 children, showing that schools could be used as an effective platform for integrated health delivery, really building on the collaboration of Ministry of Education, Ministry of Health, and showing that these programs need to align with existing policy systems and infrastructure to support ownership and sustainability. So that was a bit around the success of the project. However, what was still lacking were the tools and evidence to assist ministries in the planning and financing of these interventions, especially running these interventions at scale. Because we know that if we are not able to budget for these programs, that they will not be carried through in terms of planning and implementation. Next slide, please. So we set out to answer these questions around really exploring and identifying the cost drivers involved in running these vision screening programs, and especially running these integrated programs at scale, which would then give the ministries tools that they could use in terms of their planning and budgeting, the overall goal that they would be able to use these to support the creation of costed education sector plans. So we really set out to answer the questions in terms of what is the cost of delivering these plans, what are the cost drivers involved, and how much would it actually cost to run vision screening programs on a national scale within these countries. And we explored this in Ghana and Cambodia, using these countries as exemplars to create a costing tool that can then be used by other countries to explore these costs. And Guillaume will go over the study, and then we'll come back together when we talk about the learnings and how both the results of our own analysis as well as the tool can be used further. Guillaume?
Yes, thank you, Imran. Thank you very much. Good morning, good afternoon, everyone. Thank you for the great introduction. So my job is now to try to explain you how we reach our objectives, showing how much it costs to implement a school-based eye health program, how those expenditures are distributed, and probably the main objective was to identify and try to estimate the resource required to scale up at a nationwide eye health program in Ghana and Cambodia. Can we go to slide 9, please? So first of all, a quick look at the methodology. Promise, try to be short, but it's important to explain the costing approach we used to fulfill those objectives. So first, we collected actual expenditure that occurred in Ghana and Cambodia as part of the SHIP pilot project. We only focus on in-country expenditure. It's quite important to precise. We don't study here, we didn't analyze the global coordination or development of SHIP guidelines expenses, so only the cost of implementation of vision screening, school-based vision screening. From these actual costs, we've assigned each expenditure to an activity and a cost category, which I will show you a little bit later. From those actual costs assignment, we could have understood a bit better how costs were distributed throughout those activities, and I did identify standard costs. So how much an activity, training per teacher, for example, costs, or we expect to cost for future programs. So we derived unit costs from actual expenditure, standardized them to feed in our costing tool. And indeed, in order to do a budget impact analysis, we developed a model, a simple mathematical model, which we fit into a costing tool that I'm going to show you a little bit later, not in details. And using this tool, we project the scenario, a SHIP scenario, so recommendation for school-based vision screening in a 5 years program, where all children in primary and lower secondary school will be screened year 1, and then only new entrants year 2, etc., etc. So, Sorry, slide 10, forgot, not in control of the slides. So slide 10, here's the more visual display of the costing approach. So as I said, from actual costs, we divided them by project program planning and management, which would be more at the international level, and focus on the implementation phase, where you have setup costs and recurrent costs. From those implementation phase costs, we identified standard costs, we fed into a costing tool, and helped us to identify the total cost, potential total cost of a 5 years program. Can we go to slide 11, please? Here, another 2 slides on methodology. Here's just to show you the activities and sub-activities identified during the pilot phase. So as Imran explained, SHIP consisted of training trainers or master trainers that will cascade the training to teachers, which will be able to do a simple visual acuity test for their students. Then, in the implementation, there will be a day when teachers will screen every single student and refer them, when necessary, to an eye examination mobile team, which will then, if they need further treatment, refer them to clinic. Transportation costs will be covered, were covered in Cambodia, and we tried to standardize those costs for Ghana, where they were not covered. There was some supervision, activity, and coordination. Can we go to slide 12, please? So after assigning each expenditure to an activity, as seen before, we also assign an expenditure to a cost category, also called input. So it's quite classical categories here. So you have personnel, transportation, equipment, spectacles fall into that category, or eye ointment fall into the material and supplies category. And can we go to slide 13, please? So this is the result of this cost, this activity-based accounting, as it's called. I'm done with the methodology, now just trying to talk about the results. So first result, when we look at actual expenditure, what was the cost in Cambodia and Ghana? In Cambodia, after we broke down each expenditure by activity, we realized, you can see the outer ring, that 40% of the expenditure were related to setup costs, meaning that fixed costs, training, organization, training of teachers amounted to 40% of those costs, and that the actual implementation only represents 59% of in-country expenditure. Within this implementation cost, implementation phase, in-country expenditure, if you prefer, coordination is one of the largest share with 26%, and eye examination per se only represented 10% of the expenditure. Can we go to next slide, please? Here we have quite similar activity breakdown for Ghana, which is explained by the fact that we, from the beginning, started to use standard guideline. That was the point of SHIP, also developing standard guideline. And we find similar pattern in terms of distribution costs. Again, here, setup costs are quite high, with 51%, even higher than in Cambodia. And capacity and partnership strengthening workshops represented the largest share of the total expenditure in Ghana, explained by the fact that we might have needed longer workshops. Coordination also represents 24% of total in-country expenditure. Can we go to next slide, please? Here's the 2 pie charts combining for Cambodia and Ghana, showing the breakdown by input or cost category. Classically, personal category represents the largest share, with almost 70% for both countries. Venue rental and catering was also a surprisingly large share, but it's explained by the fact that the setup costs, as shown before, which requires lots of workshops and meetings, are quite high, relatively prohibitive. Can we go next slide, please? So finally, this table sums up the actual expenditure and breakdown by activity and input. It's a cross table that shows that cost drivers, that help to identify cost drivers actually. You see that 47% of total in-country costs for Cambodia and Ghana were represented by training of teachers, coordination, and those workshops, whereas our examination only represented 13%, a bit counterintuitive. Can we go to next slide, please? So, using those activity breakdown, now that we know that how much costed a training session, training of trainer station, and how much it costs to actually implement school-based vision screening, and during this pilot, we could calculate what we call unit cost to look at the effectiveness of our intervention. And looking at Cambodia, we've seen, as Imran already showed us before, that 12,440 children were screened by teachers, and the total cost of implementation divided by this output, results into a 2.9 US dollar cost per child screen. Well, we're talking about US dollar 2016, which was the year of the pilot. In Ghana, it amounts to $3 per child screen. In terms of children corrected with refractive error, we had uncorrected refractive error. It amounts to almost $500 in Cambodia and $400 in Ghana. So here were the actual expenditure, what we observed. So it has no, it was actual expenditure, which led to, which fed into our standardization estimation. Can we go to next slide, please? So, as I showed you in my first slide, the first step was to assign each expenditure to an activity cost category that allows us to estimate unit costs. And as we aim to have a standard way of implementing vision screening, and as we want to know for our budget projection how want to be as precise as possible, we have estimated cost of activity that did not occur in Cambodia or Ghana. So as I said, in Ghana, the transportation of children that were referred to clinic for further treatment was not covered. So we had to estimate this cost or make an allocation. Or alternatively, in Cambodia, training of trainers didn't occur because trainers were already trained during a previous project from 2012. So we had to estimate this cost per trainer. This was what we did during this standardization. And with the standard unit cost and standardization of activities, we could have built our model, projection model. Can we go to next slide, please? So here's a bit the core of our costing study. The steps before we used to understand a little bit how expenditure we distribute, how much actually implement pilot school-based vision screening, but the aim was to build a model to understand and to estimate the resource needed to have a national scale school-based vision screening program. So the idea was to develop this model only for the purpose of the study, but we realized that our Excel costing tool could be used for maybe other country first, or even other health intervention. So we tried to make a costing tool as generic as possible, where you could actually modify assumptions, even the standard costs or education data. I cannot show you the tool. I think it would take too much time, but I left my email address, and if you're interested, we're really willing to share this this costing tool in case it could help to estimate the cost of implementing such intervention in a new country or one district. But for the purpose of our study, we used assumption from SHIP guidelines and from financial data found during our SHIP pilots and our standardization. We use percentage prevalence of uncorrected refractive error observed during our study, but also found in literature. Based on this, we also use education data provided by EMIS, which is the Education Management Information System, that you might find in most countries. So they help gather information on the enrollment rate or number of students in primary, secondary school. But the challenge here for us was to estimate for the next 5 years what would be the enrollment in primary and lower secondary school in Ghana and Cambodia. So we used what UNESCO has developed called the flow model, which allows you to, from a certain base year, calculate the future enrollment. In our case, we only focus on public primary school students and primary lower secondary students. Can we go to next slide, please? So I'm really sorry, I realize this slide is not readable. Actually, it's just a screenshot because, again, I can share it with you, the tool. But when we fed all this information, all these assumptions, education data, and standard costs in this model, we end up having the cost of our 5 years program at national scale per year, per province, per activity, and the total cost of the 5 years program. So this tool, model, is based on existing literature. You can find some similar tools for the other intervention, such as the one from Baltusen. But the interesting result from our tool is that, as expected, in year 1, as the setup costs are quite prohibitive, it represents the highest share of the total expenditure, where year 2, 3, 4, 5, where only recurrent costs occur, represent only 1/3 of the first year cost. But to sum up, in Cambodia or Ghana, we estimate that the cost of a national school-based vision screening will amount to $7 million in Cambodia and 16 million in Ghana for the period of 2019 to 2023. We'll compare it to budget. We'll see that later see if it's affordable. But the first, sorry, I forgot. Can I go to next slide? Can I go to next slide, please? Yes. The first learning for this cost projection is to show that if you were to scale up, there will be more cost effective. Indeed, as we've seen earlier, during our pilot phase, the cost per child screen amounted to $2.9 in Cambodia and $3 in Ghana, whereas, according to our estimation, with the scale up, it will amount to only 1.3 in Cambodia and 1.8 in Ghana. As the projected cost per child with corrected refractive error will also decrease to $230 in Cambodia and $238 in Ghana. I could also provide you, if you ask and request, results of a multivariate sensitivity analysis to show you if we modify some variables or if our estimation were too optimistic or too pessimistic, to see that the difference is not that high. Another interesting result in comparison will be to see if we were to screen children, every single children by ophthalmologists directly and not through teachers first, the cost per child with corrected refractive error will amount to $500 in Cambodia and $549 in Ghana, representing a difference of almost twice more expensive than using the SHIP guideline. Can we go to the next slide, please? Overall, we also found out that cost savings could be made if we were to use, for example, ready-made spectacles, as Imran showed us. The SLR provided during the pilot were very cost savings. Indeed, if we gave a referral to a optic shop, very often costs would be higher when possible and as far as possible. We understand that it's not possible to provide only ready-made spectacles, but as far as possible, it should be prioritized. Screening and distributing spectacles to teachers is very important. Indeed, it also emphasizes children to comply with their treatment and wear themselves spectacles. We know that in some regions, there's still a stigma around wearing spectacles. Finally, probably the most important is the economies of scale made by this potential economies of scale. If we were to scale up our pilot to the national level in Cambodia and Ghana, as I said, we would drastically reduce the startup costs as they're mostly fixed, and it will allow us to only have recurrent costs in the following years. Economies of scope could also be made if we were to integrate visual impairment with another health intervention. during the pilots, we have integrated visual impairment with hearing impairment or even deworming in some cases, but it was more coordinated than integrated. What I mean here, what we mean with integrated, maybe should be give a focus on having training occurring at the same time, coordination workshop at the same time. Even the day out at school, the week where children are supposed to be screened should be exactly at the same time that sensitization could be done for both visual impairment and another health intervention such as hearing impairment. Can we go to next slide, please? Finally, the affordability. This was probably the main objective of our studies, was to show that a large-scale integration vision screening, school-based vision screening program could be affordable. We indeed compared the 5 years vision screening program we compare it to the national budget law of Cambodia for health and education sector. And if we combine those budgets and compare it to the 5 years vision screening program, we realize it only represents 0.5%. It's a similar figure for Ghana. It's actually the same figure, 0.5% of the combined budget for if we were to implement our 5 years program in Ghana. We realized that this is just a rough comparison. We just assume that it's affordable, but we would need to see a little bit more in details, but it gives us maybe more a better understanding on terms of the volume of the figure. Sometimes those large figures don't need much, but when we compare to the national budget, we realize that we could maybe have a base of discussion in terms of affordability. And can we go to next slide, please? Here I'm going to hand over to Imran that will conclude our presentation and present you the maybe more global learning.
Right, thank you, Guillaume. So really the analysis of the costing study shows that scale up of the programs in Ghana and Cambodia are indeed affordable, especially when you consider if the costs are shared between health and education, as well as the results confirm that vision screening of school children as described in the DCP Volume 3 is a cost-effective way vision when it's part of the essential school health package. It's really important that we utilize context-specific expenditure information. For example, prices of equipment, travel costs, etc., provide an accurate picture. And that's how you see the cost of delivering the program in Cambodia and the cost of delivering the program in Ghana. So it's really imperative to have those valid figures. When we talk about the costing tool, that we really feel that the costing tool can help policymakers and planners identify cost drivers that would support the development of a costed education sector plan. However, I would also like to say that by diving into the specific cost drivers and understanding where some of the significant costs are, there is also an opportunity that we can explore where cost savings can occur. And I'll just discuss that in just a moment. But really, the study suggests that integrating vision screening with other school-based interventions and delivering this at scale can maximize both the economies of scale as well as the economies of scope. And really, one of the main takeaways for myself when looking at this costing data was in terms of where cost savings can actually occur. That it was one of my assumptions when we planned the program, and indeed when this model was conceptualized, we thought that the leading cost would actually be due to the transport of the mobile refraction teams having coming to the school to provide the eye examinations and give the glasses out. And indeed, it was that assumption that led most, I would say, conventional school screening programs that use teachers for screening, whereby the teachers screen students and then refer students to go to the nearest eye unit to get a further examination in glasses. In the SHIP model, we actually brought those services to the school. And one of our concerns is by bringing those services to the school and providing glasses at no cost, this would make the cost more prohibitive. But as Guillaume had pointed out, that really the eye examination of the children only accounted for 10% of the costs, which was definitely an eye-opener for me, realizing that the majority of costs, about 48% of the costs, were actually in terms of the setup, the coordination, and I feel that those costs can be reduced. So that's another, I would say that was another benefit of carrying out the costing analysis, is identifying the drivers, but then identifying where cost savings could occur, and then using that to then plan how to cover an entire nation at scale. So it looks like we have some questions on the chat box. So I appreciate all of you who have asked questions, and maybe we'll go through these in order between myself and Guillaume. And feel free to type in additional questions, and we can have a questions or comments, and we can have a discussion. We've got about 20 minutes or so for that. So the first question was, besides deworming and vision screening and follow-up as entry points, were other health services provided in the SHIP initiative? So really the SHIP initiative was concentrating on the integration of deworming and vision screening. And the reason that vision screening and deworming were chosen as model interventions was more around, when we look at deworming, and we'll look at that countries often have national deworming programs. So we thought, can we then integrate another health intervention, vision screening, on the national deworming programs? And really the SHIP program was set out to ask that question around integration. With that said, I would say that looking towards the future, what I would see developing, and really the mode of travel, would be to have a number of health interventions combined at the same time, using SHIP as a platform to deliver these different health interventions. So for example, I don't see why not I should say that I would also advocate that we use hearing screening, for example, build hearing screening, maybe dental checkups, disability screening, just build that onto this SHIP platform. Therefore, you can integrate it within training. You could go out, you could create awareness around overall school health to help mobilize communities and deliver all of this health package at the same time. And as Guillaume showed us, that you can achieve those economies of scope by combining different interventions and delivering them at the same time, which would then save costs of independently conducting these interventions in a vertical fashion. So that's really what SHIP kind of set out to do, was to show that it is possible to integrate different health interventions, but I would definitely see it going wider and really incorporating other health interventions within the same model. There was a question around, are you able to go straight from the tumbling E to prescribing the ready to clips? My understanding is that there's an intermediary step required for refraction screening, and that's completely correct. So just in terms of the semantics here, that when we define screening, we define that as pass or fail. So the vision screener was just set at a certain visual acuity threshold that a teacher would be able to conduct that screening quickly. And if the student was able to see more than half of the letters, then they would be considered a pass. If they were not able to see more than half the letters, then they would have failed that screening, and the teacher would have written down that child's name to identify that child when the mobile refraction unit, which is comprised of optometrists, would then come to the school and conduct a full eye examination for the students who have failed. And I should also note that the referral to the optometrist were based on the visual acuity screening, as well as if there was any, if the student had any visual complaints. For example, if they were complaining about pain in the eye, or if they were complaining about headaches, then we would also want them examined by the optometrists. And the third criteria was if there was any visible abnormality to the eye. So, for example, if the eyes were red or if there was discharge, etc., then those children would also be referred to the visiting team. And then that visiting team again would conduct a full visual acuity testing, measure the power of the eye using refraction, and then dispense the spectacles at that time, only after a thorough eye examination. In terms of standardizing the costs of the model, that the way that we took the cost drivers based on the SHIP guidelines, where we spelled out the activities in a standardized manner, that was then utilized across the 4 countries. So the same activities were done in all 4 countries using the same model. Therefore, we were able to ascertain what the cost drivers are. And maybe, Guillaume, if you want to go over how you found out the costs of each of those activities, maybe you could say a few words about that.
Yes, but you're exactly right. We use the SHIP guidelines first, and we use actual expenditure collected during the pilot phase to calculate those unit costs, per activity, or maybe not unit cost, but cost of a certain activity, and divided by the output. And that's how we standardize those costs. It's based on guidelines and based on actual expenditure observed during the pilot phase. Should I answer the second question, which is about setup costs for year 2, 3? Because I think it's an interesting question, and we discussed. And
Guillaume, if you just want to go ahead and repeat the question as well.
Yes, of course. Sorry. Is it possible to factor in some setup costs for year 2, 3, 4, or 5 in the model 2, given the need for refresher trainings and training new teachers? So yes, it is possible. As I said, we try to make the costing tool editable, let's say, where you can add anything you want if you want to compare some scenarios together. We discuss it. I saw in the literature that refresher training sometimes are every 5 years, sometimes every 2 or 3 years. This is really, I think we can discuss it. I think we discussed it together also, Imran, already. And we consider that for new teachers, for example, we accounted for national and regional coordination costs that will occur every year, recurrent costs. And we thought that maybe new teachers could receive their training from either the regional coordinator or from other teacher, or maybe even organize refresher training within that budget. It's something, yes, good point, good question, I think.
Okay, and then there's a question around, as part of cost analysis, did you attempt to capture the benefits of the approach, for example, improved education, productivity, etc., or was that too complicated?
Well, we didn't have that much time first, and it was a retrospective analysis also, costing analysis. So we started the analysis 1 year after the pilots occurred. We considered a cost-benefit analysis would be interesting. We could still try to do it. But yeah, the project is over at the moment. It's something, yes, we could discuss. We tried also to look at DALYs, disability adjusted life years, and this is quite complicated with the incidents. We need a bit more time, yes, to do that.
Yeah, and just to make a comment on that within the costing analysis, we really did just concentrate on the direct costs. So we didn't, we were quite clear about the scope of the costing analysis. For example, we also did not look at indirect costs, for example, as well, like the costs that, the families may have had to take on. But I think there is really worth really looking at improved education outcomes in children who have been given glasses. But I think that's a whole nother study in itself.
Yeah, I agree.
Yeah, and there's a comment about integration, like child health days in Uganda, where they conduct deworming, tetanus, HPV vaccines in the same school health campaigns in collaboration with the Ministry of Health and Ministry of Education. And really, I would completely agree with that approach. And for example, if they're conducting those school health campaigns, I would actually advocate that vision screening is included within those school health campaigns. So it's really understanding what the existing policies, what the existing activities are, and aligning health programs within those campaigns, which would save you from having to carry out a vertical intervention, which again is more costly. And again, if we kind of looked at, I would say, quote unquote, the conventional way of doing things was again that the deworming program would occur where, the training would occur in isolation, the sensitization would occur in isolation, and then maybe a few weeks later, the vision screening guys would show up, pull the teachers out of schools, give them the training, and then resensitize the community. So there's quite a lot of wasted resources. You can see it in that conventional model. So I definitely would agree with looking at a way to integrate these different health interventions. For example, like the child health days in Uganda. I see there is a question around what happened with children whose eye problems were not refractive errors. Okay, so again, I described within the model that the children who were able to be prescribed glasses on the spot were given glasses at no cost. And I should also point out that the children who we were able to correct on the spot were the children with relatively simple refractive errors. And what that means is it was without getting too technical, it was a spherical, so that's a child who fit into certain prescribing guidelines. And within the standardized guidelines about vision screening, we are very specific about what refractive errors can be treated with these ready-to-clip or ready-made spectacles, and what childs would need a custom-made pair of spectacles. So we're quite clear about that, because again, we don't want to be compromising children's visual health by giving them an inadequate prescription. With that said, we had noted that we were able to correct about 80 to 90% of children using these clip system, and the children who require more complex prescriptions were then given a custom-made pair of spectacles that would be made up specifically for their prescription. So that kind of answers in terms of if you had complicated refractive error, how that would be treated. However, there were also children who required further treatment. So within the project, we did have some allocation, some budget for children who needed, say, antibacterial eye drops for conjunctivitis. So that was done as part of the project. However, there were also children who needed to be referred for surgeries. So the way that we handled those costs were that within the project and within the costing analysis, we included the cost to get the student to the nearest, well, to the appropriate eye hospital, but in terms of the surgical care, that was not included within the school eye health project budget. So the way that we demarcated that was we said that, you know, if a child does need further surgery, for example, if they have a congenital cataract or another condition, then that should be covered through the eye health budget and not the school health budget. So that's how we were quite clear about how we would demarcate those costs. And Guillaume, I don't know if you have a comment about that as well.
No, I think you covered it well. Yes. No. Yeah. As I said, for the transportation costs, it was also quite difficult to estimate, and but it's quite important. It was also the difficulty which relates to the collaboration, because budgets are quite separate from Ministry of Health and Ministry of Education, and it's quite, I'd say, an important question, because yes, they're separated budget. It's quite difficult to find the right collaboration, and they're very different, very separated sometimes. So
yeah,
we rather just focus on eye health and on education, than on specifically health sector.
Yeah, and just to kind of point out that one of the barriers within a school health program is where the responsibilities and the budgets where they sit. You know, for example, when we started at the beginning of the project with the scoping, you know, we would go to Ministry of Education and they would say, oh, if it's health, then that should be covered by, that's the Ministry of Health's responsibility. And then if you go to the Ministry of Health, they would say, oh, if it's in schools, that should be Ministry of Education's responsibility. So it's really creating that collaboration between Ministry of Health and Ministry of Education, because they are both integral to having a successful school health program. And that was definitely demonstrated by this program, because again, we would have teachers conducting the screening as part of Ministry of Education, but then we would have the optometrists who are part of the Ministry of Health then come to the schools to conduct the eye examinations and prescribe the glasses. You know, with that said, it's much easier said than done. So, but again, that was one of the main learnings, was that in order to be successful, you have to create that collaboration, which would then lead to, you know, joint planning and joint budgeting between the two ministries. So I see there's another question that I'll take, which asks, do you have a percentage of children who were screened who needed more than simple clip-on glasses that will help us plan better? So I guess related to that question is when we actually look at the prevalence of children who were screened who needed glasses prescribed. So that was based on the 4 countries. We identified 1.7% of children who were screened needing glasses. So what that tells is that actually demonstrates that it's even more important that we integrate vision screening with other health programs, because as Guillaume pointed out, that when you look at a low percentage, and if you're just going in with a vertical program, that seems quite expensive. So again, by combining vision screening with an essential package of different health interventions, that helps bring down that cost, especially when you're dealing with a relatively low prevalent condition. So out of that 1.7%, the percentage of children who needed more than simple clip-on glasses, that was around 20%. And then, of course, the cost of the, as Guillaume pointed out within this model, the cost of the ready-to-clip was $2 per pair. The cost of the custom-made varies because we would use local opticians to have that made, and that ranged from $8 to $20.
Yes.
But again, that is something that you do need to plan for, because you will have children who will not be able to be corrected by the simple or the ready-to-clip glasses. So I see
sorry,
that oh, sorry.
Sorry, Imran, this is Jeannie. Just wanted to say if you can answer one last question, and then we leave a couple minutes at the end to announce the next webinar.
Okay, sure. So there's a there's a question in terms of geographic variations as well as next steps. So maybe I'll just try to answer both of those very quickly. So geographic variation, yes, we do see geographic variation, definitely between urban environments and rural environments. For example, in some, urban settings in Asia, we can actually see prevalence of refractive error being as high as 80%, versus in some rural African settings, we see prevalence, at around 1%. So within the model, you have to understand what the prevalence is, because again, that will impact the costs of carrying out the model. But as Guillaume had described, that within the model, you're able to customize it for the setting. So it's important to have that accurate data going into the model to help you estimate that. And one last question in terms of next steps. So we're eager to utilize this model, the costing model, to help us plan programs. And we're already looking at large-scale programs in other countries, really validating this costing tool to be used in different settings. For example, we're planning a shift type approach with deworming and vision screening on a large scale in Liberia, and we plan on validating the tool there, as well as consolidating the learning from this, looking at some of those other aspects around educational outcomes, as well as compliance wear with spectacles. So I think we might be out of time, but please feel free to either drop myself or Guillaume an email, if you want access to any of the resources, or if you have any other questions.
Thank you, Imran and Guillaume. I think I want to kind of highlight Doug McCall's comment towards the end about how this kind of research and these tools are so important for scale up and really creating sustainable programs and approaches. So he mentions we should explore how the tool and this process can be disseminated so that governments can plan ahead. I want to thank both of our speakers today for sharing their research. I know this kind of experience is really important for practitioners in their advocacy efforts in school health. So thank you again. And for everyone on the webinar, please stay tuned for our next invitation. October 15th will be the next School Health and Nutrition webinar, fresh webinar, and we'll be commemorating World Food Day on October 16th. Thank you, and have a wonderful day or wonderful evening.
Great, thank you.
Thank you, bye.
Bye.